The introduction of Casemix has been underpinned by a long-term strategic approach from research and development to strategy and action plans, through until now with the implementation of Casemix into our national collection. Here are some of the strategic documents that have underpinned information development. Moving Forward, for example, was published in the late 1990s. Our Mental Health Information National Collection, AMHOIC, began to collect activity data from clinical services in 2000. Work on outcome measures through the Mental Health Standard Measures of Assessment and Recovery, the AMHOIC SMART program, began soon after. The AMHOIC SMART program looked at a number of outcome measures, including the development of a consumer outcome tool. However, the Ministry of Health has only mandated the Health of the Nation Outcome Scale, HONOS, for national collection. The Mental Health Information Strategy of 2005 and the accompanying action plan of 2006 signalled a move away from a focus on information collection and outcome development to information use. This slide provides a snapshot of the mental health and addiction services in New Zealand for the 2012 year. 146,000 people, over 3% of the population, access specialist mental health services, mental health and addiction services. 19,000 people access services only once. 15,000 people are seen for more than 2 years. This is the people planning group I talked about yesterday. 7,000 adults are admitted acutely. About 1,000 people are secluded, and 5,800 people are compulsorily assessed under the Mental Health Act. On these and other metrics, there is significant variation in rates between district health boards. This variation has sometimes been explained by services asserting they have more complex high-needs cases. Casemix may help to determine if this is so. So what is Casemix? Casemix is simply defined as a mix of cases. Casemix groups patients' episodes into clinically meaningful categories with homogeneous resource consumption. Casemix allows the identification of clinical differences in groups of patients, as well as identifying variation in service and clinician practices by comparing similar groups between different providers. So essentially, Casemix allows the comparison of like with like cases. Casemix has also been defined as a scientific approach to classifying the output of a healthcare provider. New Zealand Casemix is based on the CHAOS study, the New Zealand Mental Health Classification Outcome Study of 2003, which in turn was based on MHCASC, the Australian Mental Health Classification and Service Cost Project of the 1990s. New Zealand Casemix, the CHAOS study is the only evidence-based proof Casemix was possible. However, it did not prove that it could make a difference. It is on this background that New Zealand Casemix capability has been advanced. Casemix covers clinical and community and inpatient services for adults and children. The New Zealand Casemix does not include alcohol and drug services, nor NGO services in the calculation of the algorithm. We have, however, built in the possibility of including what activity data contributes to a case class, but I'll come back to that later. So what is a case class? As I've said, Casemix covers specialist community and inpatient services for child and youth and adults. I'll focus my discussion on community examples only. A community class is premised on episodes of 91 days plus or minus 14, bounded by a HONOS collection at the beginning and the end of each episode. This is called a matched pair. The variables which emerged as defining the case class allocation that have similar resource consumption is, as you'll see, a mixture of patient characteristics and clinician perspectives. Casemix uses the following variables to determine what class a particular episode will be allocated to: a person's age, their ethnicity, legal status, HONOS score, and focus of care. There are 4 focus of care classifications, and they are acute, functional gain, intensive extended, and maintenance. So as an example of a case class, a 56-year-old being treated in the community with 2 HONOS outcome collections, 91 days plus or minus 14 apart. They are voluntary, are of European ethnicity, and have a functional gain focus of care. It means they get allocated to assigned to a particular class, in this case the AC05 class, whereas the same individual with an involuntary acute admission and a HONOR score for hallucinations of less than 3 was allocated to a different class. New Zealand Casemix has 42 different classes, including assessment, that can be rolled up into 7 branches. The 7 branches are adult community, adult assessment only, child and youth community assessment only, child and youth community, adult inpatient complete, adult inpatient ongoing, and child and youth inpatient. So what is the purpose of Casemix? Casemix has a quality improvement function. Casemix has been used to improve the quality of care through the ability to compare like with like cases and improve outcomes to a high and consistent level. This is what we hope to use Casemix for in New Zealand. Casemix has also been used for output measurement. We could simply count the number of cases, classes or branches. For example, 3,000 cases treated sounds more impressive than 146,000 people. That is if we could capture most of the service activity in the classes. We are a very, very long way off from doing that, if ever. The chaos study also cost-weighted the classes because of their different resource consumption. So, for example, the 56-year-old in the community class I mentioned in the previous slide has a case weight of 0.27, whereas the person with an involuntary admission and a HONOR score for hallucinations of less than 3 has a case weight of 1, meaning that class is 4 times the cost of the community class. So in theory, we could adjust for case complexity. New Zealand is not going down the output case weight path, as the chaos study cost weights are out of date, and there is also concern over the potential for gaming HONOR scores if we link classes to output performance. In terms of funding, Casemix has also been used as the basis for funding general hospital services. That is, buying a certain number of cases, say hip replacements. I understand the state of Victoria uses Casemix as a basis for funding hospital services. However, without a clear understanding of the Casemix cost drivers, it is difficult to see how a funding model based on Casemix could be introduced that does not run the significant risk of introducing perverse incentives such as gaming HONORs. And that is even if we could collect a reasonable measure of activity data in the case classes. I'll come back to that issue later. There is absolutely no intention in New Zealand to fund mental health services by Casemix. The 2003 chaos study I mentioned earlier provided the evidence to introduce the HONOS suite of measures into New Zealand clinical mental health services. HONOS underpins Casemix as a quality improvement tool. The HONOS family has 5 scales: HONOSCA for children, HONOS for adults, HONOS 65 for older people, HONOS Secure for forensic services, and HONOS LD for people with learning difficulties. The adult HONOS measure has 12 items, ranging from problems with hallucinations and delusions through to problems with occupation and activities. These are rated on a 0 to 4 scale, with 4 being severe problems. The lowest score possible is 0, the highest possible score is 48. It measures clinically rated health and wellbeing changes over time. HONOS changes are useful for clinicians and clients to monitor progress. I've heard about clients seeing HONOS as a way of measuring their own progress, seeing it as a bit of self-competition, and also by helping clients to see that perhaps they're not as sick as they thought they might have been because of their low HONOS score, and based on that have moved on to employment. I'm all for what works. The program for the integration of mental health data, PRIMED, was established in 2008 to collect activity and HONOS data from 20 district health boards, clinical mental health services, and activity from 250 of our NGOs. It superseded our Mental Health Information National Collection, AMHOIC, which was based on specialist service activity data only. PRIMED collects HONOS data according to the outcomes collection protocol derived from the chaos study for inpatient and clinical community services premised on the 91-day episodes, as I've said. The PRIMED data is collected according to a set of standards and validated when loaded into the system. The code set for PRIMED runs to 55 pages. Data is collected by the person's NHI, a National Health Index number, which is unique to the individual. The data is reported to PRIMED according to the referral source and the referral end code and the type of activity undertaken. For example, was it a face-to-face contact with family not present or an acute bed night? The referral source codes include primary care and justice, for example. Referral end codes, for example, cover was a referral ended routinely or was it ended because gone no address or lost to follow-up. Prime also collects Mental Health Act status, seclusion and ECT data. As I said earlier, the Ministry of Health published HONOS data and from Prime, this graph shows what we publish. As with Australia, we can tell a HONOS outcome story. In the left-hand section of the graph, we can see that the national average HONOS score for 6,731 inpatient admissions was 14, and the average discharge score was 7, a 7-point improvement. In the right-hand section of the graph, we can see that the national average HONOS for 20,100 community admissions was 10, 4 points lower than the acute admission, and the average community discharge score was 5, an improvement of 5 points. This table provides another example of Prime HONOS reporting. The New Zealand District Health Board Key Performance Indicator project has a key performance indicator called the Index of Severity at acute admission and discharge. This looks at the changes in HONOS score between admission and discharge and draws the data from Prime. The Index of Severity is comprised of 3 categories: a significant improvement, which is defined as a reduction in HONOS score of 6 or more points between admission and discharge. No significant change means a score of 5 or less. And the significant deterioration category is where, is where there is a 6 or more point increase in HONOS scores between admission and discharge. In this District Health Board example, the table shows the number of Maori, Pacific and other ethnicities and gives an overall score of the number of people who fit into each of the severity categories. So looking at the right-hand side of the table, overall in this District Health Board, 168 people showed a significant improvement between admission and discharge, 59 people showed no change, and 1 person was significantly worse. There were 51% matched pairs, that is people who had both an admission and discharge HONOS collection. While this example only shows 1 person who significantly deteriorated between admission and discharge, other district health boards have quite a number who have deteriorated. We really need to understand why this is so, and to PO undertaking some work for us to try and understand what's happening. A complex algorithm based on 36 business rules has been implemented into the Prime system. We began this work in 2011 and it is now nearly complete. This is 10 years since the Chaos study was published. The algorithm selects only matched pair episodes and distributes the episodes into the 42 different classes. It has been a very difficult process to implement. We've had significant support from Te Pou, who developed a Casemix prototype to support the development of the final product. However, we had a very enthusiastic programmer who decided in order to make the algorithm run faster, he would program the business rules out of order. And this had a significant impact on our ability to extract valid episodes from the data. We had to go cap in hand to our major capital committee for extra funding to rewrite the algorithm. They weren't very happy, however, they granted us the extra funding. Clearly this significantly delayed the project. It means I'm only able to present 2 example reports today using live data. Prime Casemix will provide 12 standard reports and the ability to run ad hoc queries Case class reports can be drilled down to the individual NHI level. This slide provides a brief overview of the standard reports that will be available to DHBs, the Ministry and Te Pou. The reports can be grouped into 5 categories. The first report is the number of outcome episodes by Casemix branch, both nationally and by District Health Board. The second report shows the mean improvement in HONOS, HONOSCA and HONOS 65 and total HONOS score by class, both nationally and by DHB. I will come back to these two reports shortly and show the actual reports coming out of Prime. The third group of reports looks at the Casemix adjusted relative mean improvement in HONOR scores by DHB teams by branch and class, which can be drilled down to the NHI or individual client level using the NHI. The Casemix relative mean improvement, also known as the CAMI score, is the calculation that compares changes in HONOR score between the mean change in HONOR score for a particular class or branch. The fourth group of reports are reports that look at prime reported activity data relative to the Casemix adjusted relative mean score by DHB branch and class. So for each class, we can see the relative change in HONOR score and what activity was undertaken. The activity includes the number of face-to-face and non-face-to-face activities for each class for each district health ward. There are three levels of reports: the activity drawn from clinical services only, data drawn into the class from NGO activity only, and data drawn in from both clinical and NGO services. This is really a pretty clever piece of data warehousing and programming logic to achieve these reports, and demonstrates the analytical capacity we have in the Prime data set. Given that case classes are designed to be homogeneous resource consumption, we would not be expecting to see significant variation in clinical activity in these reports. The fifth report is a compliance report that shows the percentage of inpatient and community activities used in episodes of care. That is the percentage of mental health activity in Prime that has been captured by the case classes. I can show you an example of two reports. I'm not sure if you're going to be able to read that, but this report shows nationally the number of outcome episodes by branch for the 2011 calendar year. This is real data extracted from the Casemix engine. So looking down the left-hand side of the table, we can see we've got about 26,000 adult community outcome episodes, over 6,000 adult assessment-only episodes, over 6,000 inpatient complete episodes, nearly 500 adult inpatient ongoing episodes. In terms of child and youth, 8,500 community episodes, 2,200 child and youth assessment episodes only, and 440 child and youth inpatient episodes. This report shows that there is about double the number of episodes here that were used in the original chaos study. This report is available by District Health Board. This report shows a sample of the mean start and end scores for some of the 42 classes nationally. The report also shows the mean change in HONOR score along with the number of episodes and the episode length for the 2011 calendar year. So for the 56-year-old in the community example I used earlier, shows up in the middle of the table. Case class 05, AC 05, adult community voluntary, functional gain, focus of care, and of European ethnicity. The class has a mean HONOR start score of 9 and a mean episode end score of 7.7, a 1.3 improvement. And there are 5,131 episodes in this class across New Zealand, with an average episode length of 80.4 days. It is also really interesting to note that the assessment-only mean score in the top of the table, shown in the top of the table, is 10.3, which is higher than either of the start and end episode scores for the community classes on that slide. We're possibly the first country in the world to implement a mental health case mix nationally, which is great, but most importantly, we'll be the first country in the world to see how useful it will be from a practical improvement point of view. Casemix offers an opportunity to delve into the detail of HONOR's outcome results. Casemix is complex and not at all well understood by the sector. Today we're working on the sector Casemix communications to improve the sector's understanding of Casemix. Casemix is a top-down process. We don't see a case class walk through the door, and it's not clear how services will be able to unpick this top-down process. though we have included the NHI, or Unique Identifier Drill Down capability for case classes, so services will be able to identify who people were who fitted into that class. We have low match pair rates, for example. We have 32,882 community and assessment branch episodes, as shown in the earlier table. This is for the 91,000 adults seen in 2011. So when you think that the collection occasions are set at every 91 days, there is quite a gap in the data. We only have a third of the people represented, never mind the episodes that should have been. We don't know the true match pair episode rate until our compliance report is available. That will tell us the percentage of inpatient and community activities and primed that were captured in the match pairs allocated to case classes. Early indications are, though, that it's about 15%. There is also a risk that there will be little variation in change in HONOR scores between district health boards and teams to enable quality improvement processes. So looking again at the mean improvement slide, this slide, as shown previously, shows the mean improvement for a number of community classes. So looking at the top of the table, we can see the ACO2 class, described as adult community, voluntary and intensive focus of care, had a zero mean of change in HONOR score for 867 episodes nationally, and an average episode length of 85.4 days. And again, the ACO5 example, the adult community class had an improvement of 1.3. The largest improvement mean score on this slide is 1.5 for the ACO3 class, which is adult community, voluntary, functional gain focus of care, and Maori. These small changes are probably not that surprising. It's a short time frame. But it does suggest variation with classes is likely to be quite small to be useful for quality improvement. It's been a long and expensive journey over 10 years to develop and implement Casemix, but we have done it, save the final testing of some reports. Casemix is potentially a useful tool for quality improvement, but there are several hurdles, or many hurdles to get over, including assessing the report's utility. Are they telling us what we expect? We need to improve the sector's understanding of Casemix and determine the practicalities of using the Casemix data at a service and team level. Thank you. Hope you haven't got too much of a headache.